Is it? My voice is audible to all of you? Hello. Right. So I think very good evening to all of you. I'm sure you might have about to finish your day, or you might have completed your clinical work. Thank you, Teleradiology and DNB board to invite me to deliver the talk about selection of inotrope in pediatric cardiac ICU. To brief you all, I am a pediatric cardiac intensivist working in SIMS Hospital as the head of the Department of Pediatric Cardiac Intensive Care Program, and I'm here to share my views about how to select an inotrope when clinical scenarios are changing in pediatric cardiac intensive care unit. So let us keep this forum interactive. If you people would like to interact regarding any of the topic, please share your views, and we can pause in between and go ahead in the discussion mode. I think if I'm not wrong, whenever we come across the situation when we all are, this sentence comes into the picture, isn't it? Abhi padhai kar lo, fir baad mein ash. So that is only true for Abhishek Bachchan, not true for all of us. Though you are currently studying the MB program and learning pediatric cardiology, cardiac intensive care, and cardiac surgery, the process and journey is ongoing. There is nothing like cash, and you all have to evolve every day in this field because it's one of the most challenging field I can ever say. Every time you get the new challenges, new kind of clinical scenario where your entire team is interacting with each other. So of course this is just to tell you about the lighter note of today's talk, that yes, why this is so. Selection of inotrope is very, very important in pediatric cardiac intensive care because of course we have to play with the inotropes whenever you want to make the cardiac output better. So in this context we have so many weapons along with us in ICU. If you say that of course every year there would be one new inotrope, new studies would come regarding the role of Milrinone, loading dose versus non-loading dose, inhale foam, Vasopressin, recent advances in Vasopressin, levosimendan, etc., etc. And we have time-tested armamentarium as well, like dopamine, dopamine, adrenaline, noradrenaline, etc., etc. So which inotrope has to be chosen very particularly for different changing clinical scenarios. We have so many armaments, but whenever a child comes with shock and impending failure, which is cardiac failure, the situation in ICU goes like this only. Arey baap re, ye kahan se aa gaye? Shock is the scenario which always makes an entire team on the toes, and it makes the life miserable whenever you are on the duty. If I'm not wrong, do you agree with me? I think I'm not able to get to your voice. This kind of scenarios are going on. You know that so many things are there with you in ICU. So many weapons, as I told you, that so many inotropes are there. But which one to be chosen? It's a big confusive stuff. So today we are going to clear up the myths and the facts about the various inotropes which we have in the ICU. But however, along with this weapons which we are talking about, which are inotrope, of course, we need to have the monitoring, because when you want to make things right, or when you want to make your baby right, when the child is suffering from low cardiac output, of course we need to judge that where the things are wrong. So monitoring is very, very important. Apart from clinical scenarios of low cardiac output syndrome, we need to have monitoring of ECG. Lot many clues would be there on ECGs, like arrhythmias, like changes in the T waves if you operated Al Kappa, pericarditis. You would have sinus bradycardia, you would have bradycardia syndrome, you would have tachyarrhythmia syndromes. So it is very, very important to have our watch on ECG. So multi-para monitoring is very, very important. And where I would like to stress upon is, along with the acid-base balance, which is a traditional role in every pediatric cardiac ICU or pediatric ICU, where we always watch about metabolic acidosis, but many of the centers, they do not concentrate upon serum lactate, where I would like to stress upon over here that lactate value, independent lactate value of beyond more than 2.2 millimole is an independent indicator of low cardiac output. It's an early sign where you would like to have the signs from the patient that the tissue and organ perfusion is not perfect. However, your pH might be initially normal, but if your lactate was 1.6 and 1.8, and suddenly after 3-4 hours when you are seeing the child is not doing good, child is hypotensive, child's periphery is cold, he is having tachycardia, low urine output, inappropriate central behavior, like for example, child is unusually irritable or unusually lethargic, it means that an organ perfusion is not well. Now, however, when you want to truly say that whether it is your clinical judgment is correct or not, this would be one of the big tool, serum lactate, which would help you to tell that the child is suffering from low cardiac output. So, my dear friend, never ever forget to send serum lactate along with your ABG. Without this, I would say that in cardiac intensive care unit, the ABG is incomplete. Okay. Acid-base balance status is incomplete. It would not give you complete information to you guys. Then comes mixed venous saturation. Again, one of the neglected tools that many of the centers, they do not use this tool to judge about the low cardiac output syndrome, where mixed venous saturation or SVCO2 saturation, which is superior vena cava oxygen saturation, if it is less than 70, is an independent marker of low cardiac output syndrome. And believe me that this the parameter has been included by 2016 PALS guideline also. So AHA also, American Heart Association, also has realized, and they have put into their guidelines that this is must to be checked whenever you are dealing with low cardiac output syndrome or when you are dealing with shock scenario. So how to judge it? Is it okay that we take the blood from any large veins and we can judge the venous saturation, or you want to have a mixed venous saturation? What it is all about? So mixed venous saturation, as the name suggests, is the saturation from a venous sample taken from the place where two vena cava join together, and which is right atrium. So if you have SVC line, which would be internal jugular venous cannulation, if you have done it, if tip is lying in just at the SVC-RA junction, that blood sample, if it has been taken and sent for the arterial blood, venous blood gas analysis, saturation in that gas sample would tell you that how your circulation is, how the child is having, balance between the demand versus supply. So, in one scenario, for example, if you want to learn that what is mixed venous saturation, I would like to tell you that if you draw ABG, arterial blood gas analysis at particular time today, for example, take it at 6 p.m. today, and we have sent the gas and ABG is saying that saturation is 100, PO2 is around 90, but at the same time, if you draw a sample from your vena cava, which would be internal jugular venous cannulation, if you send the sample over there and simultaneously do the venous gas, and saturation is, for example, 60 in that sample, then it says that your peripheral perfusion is poor. Your arterial supply from aorta is 100% oxygenation, but when it returns to the heart through vena cava, the saturation is less than 70. It means that your peripheral perfusion is very sluggish, and tissues are extracting a lot of. There is more time to extract those the oxygenation from that sluggish circulation. So when it returns back, your saturation is low. So typically these babies are having low peripheral temperature, they are cold, central temperature or core temperature is higher. Difference between these two is significantly high. Another markers of the end organ perfusion is liver function test and rising SGPT, SGOTs, your urea creates, which would also give you a clue that your creatinine would start jumping around, but of course those are the delayed or late markers. If those are indirect markers, there are not direct markers. Hematocrit, of course, when monitoring is very much important. If your child is suffering from low cardiac output, it is very important to maintain hematocrit of 30. In our setup, we maintain the hemoglobin of around 10 or hematocrit of around 30. Electrolytes, ionic calcium and magnesium are one of the most neglected part by majority of the centers, but we must look into it. Ionic calcium is again one of the marker, and you all know that majority of your inotropes do use your calcium as their pathways. So in all the pathways of inotrope Inotrope, you can say the mechanism of action of all inotropes, they are dependent on calcium. So if calcium is low, of course you are supposed to supplement this calcium, and in couple of scenarios, even IV infusion of calcium is used as positive inotropic factor. So people do start 10 mg per kg per hour of infusion of calcium whenever the child is in low cardiac output situation. Magnesium is again very much important. Low magnesium can cause torsades or certain type of arrhythmias. It can cause refractory hypokalemias, etc., etc. It's very important. So other tools, as you all must be performing a radiology, 2D echocardiography, CVP and arterial waveform analysis, which is very, very important, and we can have a separate discussion on different waveform scenarios, where then which waveform, like for example cannonball waves, which would tell you about the child is in junctional ectopic tachycardia, or a child has a prominent J waves. It means child has significant TR, despite if you don't have echocardiography on your bedside at that particular time, but this waveform analysis can tell you a lot. Like blunted arterial waveforms, which would be with narrow pulse pressure, which would tell you about tamponade physiology. And yes, there are other the monitoring parameters like Fick principle or thermodilation method to judge about the cardiac output. However, we do not use this as a routine in children. So, if you take inotropes, their mechanism of actions are more or less dependent on various receptors, like alpha 1, alpha 2 receptors, beta receptors like beta 1, beta 2, and beta 3 receptors. Where alpha 1 and alpha 2, you very well know that vasoconstriction of arteries and venoconstriction of veins are the principal outcome of stimulating those receptors, and it decreases the motility of smooth muscles in the intestinal tract. Beta receptor, as you all know, that there are three types of beta receptor: beta 1, beta 2, and beta 3. Beta 1 receptors increases the cardiac output, chronotropy, increases the impulse conduction and increased contraction, which would be inotropy. Beta 2 receptors are smooth muscle relaxants. It induces lipolysis in adipose tissues, dilates arteries to skeletal muscles, produces glycogenolysis and gluconeogenesis, increase the renin secretion from the kidney, inhibits histamine release, and beta 3 is negative inotrope, has a negative inotropy action. So after seeing all these things of various receptors, we have now monitoring ready, that your ICU is equipped with all the measuring stuff like mixed venous. You have put all properly lines. Your ECG is ready. Your multipara monitoring is there. You have rectal probe. You have peripheral temperature probe. You are measuring urine output, and everything you have. So now take a case scenario based discussion in a way that assume that you have a 12-month-old otherwise healthy child on follow-up, which infant comes to your emergency room with history of diarrhea since 3 days, cold clammy peripheries, lethargy, mild respiratory distress but clear chest, no hepatomegaly, history of low urine output, reduced oral intake, and blood pressure is 58 by 26 millimeter of mercury. So what we are struggling, guys, where we are wrong, where this child is, you are not happy with this child, and what you would be happy to do, what first step you take for this child as far as the management of this child is concerned. Are you going to use inotrope or something else? Saline bolus, okay. Anybody else is agreeing with Dr. Riyanka Gupta? Hello? How much saline bolus, Dr. Gupta? 20 ml per kg. Dr. Amit Singh says that first bolus would be given at 20 ml per kg. Dr. Riyanka says 10 ml per kg. So that's pretty interesting. It's nice discussion is going on where we want interaction to happen. So yes, there is one lobby who says that 20 meals per kg, and one lobby says 10 meals per kg, because probably Dr. Gupta is not happy about cardiac scenario of this child. Am I right, Dr. Gupta? Why 10 ml per kg? You are not happy with your cardiac scenario in this contractility or output. You are feeling that there is something wrong, so you are choosing only less 10 ml per kg liquids. Dr. Gupta, why 10 ml per kg? Okay, so I think we'll discuss it later when the guidelines are there, and we'll discuss those guidelines at the end of this lecture. How shall we proceed? Anybody else? Anybody else would like to give us the clue? Diastolic pressure is low. This is a 12-month-old, 1-year-old child. What could be the reason of low diastolic pressure? Dr. Gupta, why? What is the reason that that this is low? Diastolic pressure is low. Okay, so as far as this scenario is concerned, we are very clear that there is history of diarrhea, there is cold clammy peripheries, child is lethargic, so cardiac output is definitely not good. Reason could be whatsoever. Diastolic pressure is low, which tells to me that child is not properly filled up. Child is deficient of volume. Child is in dehydration. So as per the criteria, of course, up to 60 cc per kilo, you can have 20 cc per kilo each aliquots to be used as far as fluid is concerned. So first line therapy would be fluids. If child is not responding, no response. Now what? Now after the third bolus, there is hepatomegaly, there is rales, and blood pressure. Blood pressure is still low. You can say around 85 by 45. Yes, I think we have got the clue from Dr. Amit, who is saying that to treat as septicemia guidelines. So, okay, you mean to say that take the samples, make euglycemia, euthermia, send cultures, give first line of antibiotic, do not delay in that as per the septic shock guidelines, or you can say that surviving sepsis guidelines, but still blood pressure is low, Dr. Amit. Now what would you like to do? Any response? Friends, if this scenario comes into your hospital where you are working and the pediatrician calls to you that I am not happy, I have given 3 boluses, now child is in hepatomegaly and rales, what inotrope to be chosen? Any clue? Everybody is able to hear me? No response? Okay, fine. So as far as this scenario is concerned, it is very clear that despite of fluid boluses, child is not doing good. So now comes the picture of inotropes, that yes, it is a fluid refractory shock scenario. You have given enough fluid challenges. You have, as Dr. Amit has correctly said, that we have drawn the sample, we have treated as septicemia guidelines, we have given one hydrocortisone also. Yes, Dr. Amit is very much right that we should start dopamine. So dopamine is, as per septicemia guidelines, as per recent AHA shock guidelines, it is considered as one of the first line of inotrope. It's an immediate precursor of norepinephrine. Action is dose dependent. Believe me, this line is very important. Dr. Amit and Dr. Gupta, this action of dopamine is dose dependent. So you should be very, very careful when you are choosing this drug, because this drug is totally different in low dose, and when you increase the dose and escalate beyond 10 microgram per kg per minute, the action is absolutely different. Why? At low infusion rates up to 5 microgram per kg per minute, there is D1, dopaminergic 1 receptors are predominant, then dopaminergic 2 receptors, which predominantly affect renal, mesenteric and coronary vasodilatation along with peripheral vasoconstriction. So along with, it means that it would increase your blood pressure, of course. It would increase your systemic vascular resistance. But along with this, in this dose, it would also dilate renal vessels, mesenteric vessels, and it would cause coronary vasodilatation. So there are a few myths about this drug. Like in low dose, the dopamine helps renal circulation, and it is renal dose of dopamine. How it came into the picture, we are going to discuss that. Is there any efficacy of that renal dose for increasing urine output, or it is just a myth? We are going to discuss it later. But we are supposed to remember that this is a dose where you have no penalties. Are you getting my point? There is no penalties. But moment you go beyond 5 to 10 microgram per kg per minute, beta 1 and beta 2 receptors are predominate. It increases the inotropy as well as in D1, D2 receptors would increases systemic vascular resistance. But now it is a caution that if you go beyond 10 microgram per kg per minute, at high doses, alpha 1 receptor effects predominate, so which is penalty of tachycardia. Alpha 1 receptors would increase the myocardial oxygen demand, it would potentiate the arrhythmias, and there would be penalties like reduced myocardial or increased myocardial oxygen consumption as well. So at higher doses, you are going to tiring the heart. So believe that beyond 10 microgram per kg per minute, if you want to choose dopamine and your child is not doing good, the concept comes over here that you are supposed to choose a better inotrope and better constrictor as compared to dopamine. The second slide proves that there was a very interesting study in 2006 where Paedbury et al. Group has proved that after they have measured the cardiac output in large group of neonates and infants, where the conclusion of the study was mean blood pressure was increased at even the dose of 0.5 to 1 microgram per kg per minute. So infants, they take very minute dose of dopamine and things become well. However, the moment they have gone beyond 3 microgram per kg per minute, tachycardia have started coming into the picture, blood pressure remained almost the same. Cardiac output and stroke volume increased before heart rate has increased. So when you go to the penalty kind of dose, which is beyond 5 microgram per kg per minute, already cardiac output and stroke volume has started rising up. Systemic vascular resistance did not change with the range of 0.5 to 6 microgram per kg per minute. So this dose is not increasing the peripheral vascular resistance in such an extent where your tired myocardium would be tiring further. So if your systemic vascular resistance goes much beyond where your heart can perform well, it would be a penalty dose in a rough language or in a simple language or a layman language. Thus, newborn men exhibit clinical response at even 3 microgram per kg per minute. So now do you agree that these slides have changed your practice? How many of you were using dopamine at beyond 10 mics per kg per minute or 15 mics per kg per minute? Have you ever used this drug at 15 microgram per kg per minute? Yes or no? You have never used this drug beyond 10 microgram per kg per minute? Up to 10, right? So, but yes, do you agree that many centers or pediatricians, they do use this drug in 12 microgram per kg per minute, 11 microgram per kg per minute, or even 10 microgram per kg per minute? Do you agree with me? Yes. So this is the where a practice should change. In our center, we rarely go beyond 5 microgram per kg per minute, and if you will interact with people like Boston Children's Hospital or in Berlin, where I have also worked in pediatric cardiac intensive care unit, people have not used dopamine since quite many years. So they use this drug as very rarely. So if you are to use in low dose, take-home messages would be here as in infancy, do not go beyond 6 microgram per kg per minute. So Dr. Amit has told that he has used till 10 microgram per kg per minute. Dr. Gupta has also told that yes, up to 10 microgram per kg per minute, you have used this drug. So here take-home message would be that if we are getting the same benefits at less than 6 microgram per kg per minute, why to go beyond? Low infusion rates of dopamine are frequently used as augmentation of renal function. Can we justify that? It means that is there any renal dose? Is there any renal dose? Answer is no. A large randomized double-blind placebo-controlled study of low-dose dopamine administered to critically ill patients at risk of renal failure never shown any benefits as particularly renal dose. The study group and the control group did not differ in the peak creatinine concentration, need for renal replacement therapy, or length of ICU stay at all. So there is nothing like renal dose. The benefits of dopamine by increasing the cardiac output and augmenting the renal vasculature or renal vascular resistance in an augmentation way it itself increases the urine output. So it is not a renal dose, but it is increasing the cardiac output, which increases the urine output. It is not that it is going to reduce your chances of peritoneal dialysis, or it is going to reduce your creatinine. Many centers, I have seen that the surgeons, the anesthesiologists, they do use renal dose of dopamine, that if creatinine is rising, start dopamine. So that's a wrong concept, and nowadays renal dose of dopamine is not at all being used. So take a call as per the clinical scenario. Dopamine is recommended as a first line agent for children with fluid refractory septic shock. As Dr. Amit has correctly said, dopamine is also appropriate for children with mild impairment of myocardial function and hypotension after resuscitation from cardiac arrest. So are you getting this point? It is a time tested formula that in these two scenarios, yes, dopamine is worth to be used. But severe impairment of vascular tone like vasoplegia or reduced cardiac contractility suggests need for better selective inotropic agent as dopamine or milrinone. So if your contractility is severely impaired, do not think that dopamine is going to solve the purpose. You have to choose a better drug. We need very high infusion rates of dopamine to improve signs of severe myocardial dysfunction, and which may cause troublesome tachycardia or dysarrhythmia and may increase the myocardial oxygen consumption. So, as a easy to understand language, I would say that rash driving comes with penalty. It can cause accidents. So do not go beyond 6 microgram per kg per minute. Now let us take case scenario 2. 4-month-old child with failure to thrive with history of recurrent lower respiratory tract infection comes in ER with severe respiratory distress, wheezing, liver 4 cm palpable, CFT, you can say the capillary refilling time is poor, periphery is cold, pulses are weak, tachycardia of 176 per minute and blood pressure is low. For this 4-month-old child, you can say, I will say that 54/35 was the blood pressure. Now what is your diagnosis? How shall we proceed? Can we have interaction over here? 10 ml per kg of saline bolus. Yes, I would agree with this, that yes, Dr. Gupta is very cautious that this where cardiac output could be low. She would like to try with lower fluid liquids. So that is okay. I would be absolutely happy. Little bit of judicious use of inotropes. Now Dr. Amitava has done this X-ray. He was not happy that no, I would not like to give fluid. I would like to judge that how is the cardiac output, and first I would like to do the X-ray. Do you agree that it is fine? And if yes, this is the X-ray, what should be your next step? What should be your next step? What should be your next step? Which inotrope to be used? Any answer? No answers. Okay. I will clear this myth. How to judge? Not to give fluid, or Dr. Gupta has given the fluid, I did not choose fluid, no other answers for other DNB residents or DNB participants who have not told. None of us has responded that yes, I would like to give fluid more. Rather to choose inodilators. Which one is quick and reliable method about selection? How to judge? If I will give you IVS, okay, IVC, okay, that's very interesting. Dr. Riyanka is saying that if I am not able to make a decision that to give fluid or not to give fluid, to choose inotrope first or fluid first, bedside IVC collapsibility index is one of the very, very good marker, not the X-ray or lectin. Both are true at their own places. But if you want easy, quick, reproducible method, reproducible means that today Dr. Riyanka is doing at this 6:30 p.m. she is checking the IVC collapsibility, and if IVC collapsibility says that fluid to be given, she can again reproduce this test and judge that yes, whatever action she has taken, it has given fruit or not. Am I right or wrong? It is called as reproducibility test. So it is very, very important to see that what is your IVC collapsibility. How about non-invasive CAP measurement by echo, which all of you should know, and I am sure you all would be doing. When a large-scale study was done regarding, IVC diameter and a predictable CVP at that time, it was found that end expiratory IVC diameter of 10 mm or less is predictable to a CVP of less than or equal to 10. An IVC diameter of 15 mm or more is predicted to a value of CVP of more than or equal to 15, which has high sensitivity and specificity. So this study was done by Vivart-Varapan and et al., which has proven a strong correlation between subxiphoid and expiratory IVC diameters and CVC. So this is again a similar echo image, which is showing a good collapsibility of IVC, which is more than 50% on M mode. And in another this image, what do you think? What is the collapsibility in inspiration and expiration? Dr. Gupta? Less than 50%. So it is not collapsing. Less than 15%. This is very true. Dr. Singh is absolutely right that collapsibility of these two measurement, it is 1.61 centimeter and 1.77 centimeter. So it is hardly less than 15%. So it is not collapsing. In this scenario, would you be happy to give fluid? No. So here we are not supposed to give fluid. I totally agree with you. This is the video of IVC collapsibility. I would like to know from you, is it more than 50% or less than 50%? Any other clue? Any other clue? So visible collapse of more than 30%. I would be happy to count. This is of course to say that it is a subjective phenomenon. Right, so here we have not taken the measurement, but overall look says that collapsibility in inspiration and expiration is more than 50%. So if your child is not on positive pressure ventilation, it is one of the very good tool which would give you reproducible numbers, that what was your cardiac index, what was the CVP, and what was IVC maximum diameter in centimeter. So if you want to take a correlation between IVC diameter, cardiac index, and CVP in children, this is a very good slide which would tell you that if your IVC maximum diameter and expiratory diameter, if it is less than 1.5 centimeter, it is total collapse, 100% collapse. Your CVP would be 0 to 5. If your diameter is 1.5 to 2.5 centimeter and more than 50% collapsibility, your CVP would be correlated between 6 to 10. So here you can take a call. It's a gray line. 6 to 10 could be a normal CVP where, however, you can take a fluid challenge. Here fluid challenge still can be given. But if your diameter is 1.5 to 2.5 centimeter at end expiratory subxiphoid view and collapsibility is less than 50%, your CVP is predictable to 11 to 15. Where we are not able to give fluid. Am I right? 11 to 15 CVP is high. If it is more than 2.5 centimeter and less than 50% collapsibility, your CVP predicted CVP value would be 16 to 20. And if it is more than 2.5 centimeter diameter and no collapse at all, it is like standstill IVC in inspiration and expiration, your chances of true value of CVP of having more than 20 is very, very high. So if you need to tell that till here I am happy to give fluid, but beyond this I would not be happy to give the fluid. However, as Dr. Reena has correctly said, in this kind of scenario, if you have echocardiography bedside, if not echocardiography probe, if you have a routine sonography probe also, this view can be easily created, subxiphoid view, and expiratory diameter of IVC 2 cm below the insertion of IVC into the right atrium. So it is very, very important to know that this is a reproducible marker, and here you would like to choose fluid and dilator. I would not be happy to choose over here dopamine first, but I would be happy that yes, if IVC is dilated, your myocardium is not working well. I would like to kick this heart very well with inotropy and would be choosing inodilator effect. So inotrope plus inodilator effect I want. What are the choices available over here? What are the choices available over here, my friends? Dr. Gupta, Dr. Amit, do we have any more participants? Please make it a dialogue so that we can interact and correct each other. Which inotrope you would be happy to use over here? Adrenaline, noradrenaline, vasopressin, dopamine. If 4 choices are given in this scenario where IVC collapsibility is less than 50% and for example CVP is around 11 to 15. In this scenario, which should be your inotrope? CVP of 11 to 15, IVC diameter and expiratory is around 2.5 and collapsibility is less than 50%. Which inotrope would be your first line? Dopamine or Milrinone, right, very good. Anybody else? Anybody else would be chasing the decision of Dr. Gupta, or you are happy? Dr. Amit, any clue from you? Why not adrenaline or vasopressin? Can you answer me? Why not vasopressin? Okay, so we go ahead with the discussion that why not vasopressin. Vasopressin is a strong vasoconstrictor. There would not be any inotropy action over here. So I do agree with Dr. Gupta that yes, she has chosen dopamine versus milrinone. Dopamine is an analog of dopamine, a potent beta receptor agonist. Beta 1 effect is more, which would induce the contractility, weak beta 2, and a later alpha agonist. Does not depend on norepinephrine release at all from peripheral nerves. So there is no requirement. The dopamine is independent on norepinephrine release, in contrary to dopamine. Dopamine is norepinephrine release is required because it's a norepi analog. Where ideal to use and where not? I think I need answers from you guys. This drug is ideal to use where and where not ideal. For example, BP is preserved. Okay, one answer is blood pressure is preserved. Dr. Gupta, do you agree with this? Okay, she is away it seems. Where ideal to use? Where? Cardiomyopathy. Okay, yes, very good. One of the indication is cardiomyopathy. For example, your surgeon has done a VSD closure, ventricular septal defect, multiple ventricular septal defect closure has been done. There was a large Dacron patch or pericardial patch was used. After that Dacron patch closure, your interventricular septum is not moving and child's contractility is less. Child's left ventricular ejection fraction is around 25%. Child has severe pulmonary arterial hypertension, and now you want to choose dopamine. Your surgeon says start dopamine. Would you be happy in this scenario, or only cardiomyopathy is the indication? Would you be happy, yes or not, to start dopamine? Yes, of course. Any cardiac output which is reduced and where you want to induce inotropy and you want to reduce peripheral resistance, this is a very good inotrope to be used. It is inodilator. It should be used in caution. Sorry, I think this echo slide is not working, but cardiomyopathy, as you have correctly said, You know about it, right? In sepsis with myocardial dysfunction, dopamine may be beneficial in conjunction with vasoconstrictors such as epinephrine or norepinephrine, not alone. So, if you have myocardial dysfunction, but you are suspicious about sepsis also, that your neutrophils is high, your WBC counts are high, and child is having severe high-grade fever, dopamine is not a good drug to be used alone. You are supposed to have a mixing of two inotropes, where dopamine would increase the inotropy, epinephrine also would increase the inotropy, but however, it would produce a good systemic vascular resistance as well. So in sepsis without cardiac failure, however, dopamine is better not to use. So these are two take-home messages you are supposed to keep, that yes, okay, dopamine is a very good inotrope with inodilator, but it should not be used in sepsis without cardiac failure. If cardiac failure is not there, if it is a pure vasoplasia, dopamine should not be used. Rather, epinephrine or norepinephrine should be used. But if you have isolated cardiomyopathy or cardiac contractility issue, dopamine is a very good drug, where BP is preserved, where Dr. Gupta has commented. It increases the cardiac output with relatively low chronotropy activity and low arrhythmogenic potential. However, in higher doses, it can cause arrhythmias. It maintains favorable hemodynamic changes over a period of days to weeks. So there are concepts of pulse regimen, like we have currently a Fontan circulation where Fontan is not doing good. So we, at couple of days of time, we wean off dopamine, and again when child is not doing good, Sunday to Sunday, kind of Saturday, Sunday or weekend therapy. There are many trials for this kind of therapy, where if your child is waiting for surgery, if you have large VSD, you give dopamine for a couple of days and take for the surgeries. If you have Fontan circulation which is not doing well post-surgery, and he was off inotrope initially, and now after starting, fluids and all, child has started taking fluid and feeds on his own, suddenly child has started showing edema. So child's little bit of a cardiac output left ventricular ejection fraction is low. Then yes, this drug would be a good drug to be used. But however, as I correctly told you, that it is not hard and fast rule that single inotrope would be better. It is always said that mixing of wine is better. You would not like one wine, but mixing of wine would be more tastier. So the same thing would be true over here as well, that you are supposed to choose two combination of inotropes. With dopamine appears to lower ventricular filling pressures as well as PVR and SVR more effectively. So low dose dopamine or low dose adrenaline and dopamine would be a good combination in cases like cardiomyopathy, post-cardiac surgery VSD, post-cardiac surgery, arterial switch operations, etc. etc. You can use afterload reducing agents like nitroprusside, NTG, or phosphodiesterase inhibitor like Milrinone, which Dr. Gupta has correctly said, in scenarios like post-PDA ligation, post-coarctation repair. Here I would like to show you a video of post-PDA ligation syndrome as well, where Milrinone with SNP was used, because moment you close a large PDA, you are going to have a severe hypertension. Moment you correct coarctation of aorta, you are supposed to have a severe hypertension. So those hypertension has to be better dealt with combination of dopamine, nitroglycerol or dopamine and SNP. Are you getting my point? Alone dopamine would not be perfect for all the situation. You have to choose it wisely. Like cardiomyopathy, which Dr. Gupta has said, you need not to have only dopamine. You may have adrenaline and dopamine. However, if you are closed duct where hypertension is not a problem, hypertension is a problem. If you must be aware that it is known as post-PDA ligation syndrome, where moment you close the PDA, your LV function reduces and severe hypertension occurs. So in that scenario, you would use dopamine with phosphodiesterase inhibitor or nitroglycerin or SNP infusion. Is it clear? One inotrope is not sufficient. Use as low as possible and titrate your hemodynamics. Studies have shown that increase in cardiac index and decrease in SVR with even low dose of 2.5 microgram per kg per minute of dopamine causes a good recovery of a child without significant increase in the heart rate. So now if you go to adrenaline, as we had discussed, the dopamine and adrenaline, where this should be used. This is an endogenous catecholamine released from adrenal medulla, as you are very much aware, and it's a very, very potent inotrope. in dose of 0.05 to 0.1 microgram per kg per minute. Adrenaline exerts only beta 1 and beta 2 effects with lower systemic vascular resistance effect. But if you go beyond 0.1 microgram per kg per minute, it induces both alpha and beta effects. At further high dose, which is more than 1 microgram per kg per minute, the alpha effect predominates. So, what my message over here is, up to this dose, your adrenaline also would be happy to serve the beneficial effect to dopamine, as only beta 1 effect is there, beta 2 effect is there. There is no much alpha activity. Alpha activity starts from beyond 0.1 microgram per kg per minute. So, when you are going to use this drug in higher dose, it would cause a very good effect on blood pressure. But if you use in lower doses, it would be more contractility as well as effect on blood pressure. During infusion of epinephrine, hepatic and splanchnic blood flow increases, with renal blood flow would be reduced. So very, very important to know that adrenaline causes, high doses of adrenaline would cause reduced urine output. It would cause higher hepatic enzymes. It would cause higher lactate values, and it would cause hyperglycemia. Clinical scenarios where it would be used, indications are cardiogenic shock, septic shock associated with reduced stroke volume and hypertension. Shock following severe hypoxic ischemic insult, post-arrest situation, post-cardiac arrest scenario, dopamine-resistant hypotensive shock, and bolus doses used for anaphylactic reaction and for acute bronchial asthma and resuscitation. First, keep in mind that dopamine decreases the lactate and increases the arterial pH, whereas adrenaline was associated with higher lactate value, higher sugar value, and infusion of beyond 0.1 microgram per kg per minute had lowered serum potassium as well because of the beta 2 agonist activity. So penalties has to be kept in mind. Use comes with penalty as well. This is again another case scenario. Somehow the function, the echocardiography is not clear in this image. This is a 2 years old, normally growing child, history of high grade fever, low urine output, motor peripheries, rash all over the body, lethargic, acidotic, feeble pulses, no structural heart disease at all. This child was routinely followed by a pediatrician and there was no problem of the heart. What is the situation? 60/30 blood pressure, rash all over the body, and heart was hypercontractile. Hypercontractile. Can you tell me where we are struggling? Where we are struggling? Septicemia. Is it okay? The comparison of these three drugs, norepinephrine, epinephrine, and isoprenaline, it is very clearly said that epinephrine and norepinephrine is almost reproducing similar effect. So if you see in the doses of 10 microgram per kg per minute of all three drugs, which is norepinephrine, epinephrine, and isoprenaline, norepinephrine shows in the same dose better systemic vascular resistance. However, the pulse rate would be low. It would not induce tachycardia, rather it would be reducing the baseline heart rate. Epinephrine would give the penalty of tachycardia, and isoprenaline would be more dangerous to produce tachycardia as compared to norepinephrine or epinephrine. So is it okay? Are you able to get my message over here, that in this kind of scenario where you are struggling with septic shock, where high grade fever, infection is the problem, then definitely norepinephrine is a better drug, or vasopressin is a better drug. Why? Vasopressin is an excellent drug and it's a recent addition to PIC practitioners' armamentarium, and its use may elevate blood pressure and urine output in catecholamine, refractory, vasodilatory shock. So each of this word is very, very important. Catecholamine, refractory, vasodilatory shock. Vasopressin should never be used in setting where impaired myocardial function or cardiomyopathy is a primary problem. So this is a potent vasoconstrictor, and it would induce a problem to a failing heart. So you should be very, very careful. However, post cardiac surgery, post arrest scenario, neonate with arterial switch operation, neonate with severe pulmonary arterial hypertension, this is a very good drug to be used. Very economical, 62 rupees is the only MRP. If you see the doses is a wide range. We start with 0.002 unit per kg per minute, and we never go beyond 0.002 microgram per kg per minute dose. In those dose regimen, control trial says that in pediatric age group, many studies are required, and this is a very, very good drug to be used. But in the higher dose, beyond 0.002 unit per kg per minute, yes, penalties like tissue necrosis, elevated hepatic enzymes, gangrenes, ischemia, these are a very, very common finding. This is one of the child's photograph where I can tell you that just hold on, my laptop is showing reduced battery. I would just connect it. Used in caution. As we have already discussed, that there are other inotropes as well, like calcium, and this is the the slide which can tell you that each inotrope needs intracellular calcium availability. Then and then they would be used. Like for example, if you take epinephrine and norepinephrine, that it would be stimulating the beta 2 receptors, alpha 1 receptors, and ultimately you need this calcium entry, and at that time only there would be troponin and myofilament combination coming together, and there will be an active interaction between actin and myosin filaments. So calcium is very, very important. Ionic calcium has to be measured. Whatsoever inotrope you choose, beta 2 effect, alpha 1 effect, everywhere intracellular calcium availability is a must. So what to do if calcium is low? Or is there any inotrope which is not dependent on calcium? It is not dependent on any of these receptors. Now let us chase discussions on that aspect. So this is a third case scenario where there is a neonate who is 3 days old. There is a severe birth asphyxia. Is it audible now? Yeah. So this is a neonate with 3 days old, severe birth asphyxia, ventilated. Sequels are urine output is 0.9 ml per kg per hour, periphery is cold, SpO2 is 92. You have the full history in front of your screen. Now I would like to know that what shall we do? Which inotrope to be used? Heart rate is high, right upper limb saturation is 92, lower limb saturation is 82, BP is 48 by 36. Dopamine of 5 microgram per kg per minute is already going on, and ABG is suggestive of severe metabolic acidosis with higher lactate values. What is your input, dears? What is your input? I would need your inputs, doctors. Which inotrope to be used? Are you able to hear me? Dr. Riyanka, Dr. Ambar Kumar, and Dr. Amitosh. In this scenario, which inotrope you would be happy to use? Okay, I think probably I would tell you that one weapon is quite effective over here, and which we are talking about is bipyrimidine derivative. Why? Why Milrinone? For example, if we are given an answer Milrinone, is that true or not? Yes, of course. Here only contraindication to this drug would be lower blood pressure. We need to bring this blood pressure a little bit higher and use Milrinone in combination of adrenaline or dopamine. So dopamine is already going on in this scenario. We would be happy to jump up from 5 microgram per 10 microgram per kg per minute of dopamine and start using Milrinone. So Milrinone doesn't require any receptor. It is not dependent on receptors. It is non-catecholamine. It doesn't produce any down regulation. It is safer comparatively as compared to other drugs, less arrhythmogenic and synergistic to other inotropes. Has all three advantages like inotropy, lucinotropy, chronotropy, and reduces the pulmonary arterial hypertension. So it is good for the left ventricle as well, and it is good for the right ventricle as well. It is less costly because loading dose is no more recommended, or there is no use. I will show you the study which says that this is a very good study. You must be knowing this guy name is Dr. Patrick, who is from Sick Kids Children's Hospital, Toronto, and who has produced a very big randomized control trial in which he has proven that Milrinone improves oxygenation in neonates with severe PPHN. Like, do you all agree that this is a PPHN scenario? Now, why we are discussing Milrinone? Have you got this? This pre-ductal saturation is high, post-ductal saturation is low, blood pressure is borderline, and child has severe lactatemia. Urine output is less, is already ventilated, and has a trigger like severe birth asphyxia. So all of you do agree with me that we are discussing this scenario, which is PPHN scenario. We are here in this case scenario 3. Yes, absolutely. So now I am getting that you all are here. So we are here discussing PPHN scenarios, and Milrinone is one of the very, very good modality. And this study is one of the very landmark study which is done in the Hospital of Sick Children, Toronto, as I discussed by Dr. Patrick, who is the head of the department there. And he has done a lot of study in post-pedialization syndrome, post-arterial switch operation management, and neonatal persistent pulmonary hypertension. And this study, he has proven that Milrinone reduces the heart rate, it improves the oxygenation index, and it reduces the chances of tachycardia, which is very common with other inotropes like dopamine, adrenaline, etc., etc. So if you see this drug which correlates that inhaled nitric with Milrinone, when it was used in their unit, oxygen index has improved, heart rate has reduced, and when they have used only inhaled nitric oxide, this was not the scenario. Oxygen index has not fallen or improved as compared to use with Milrinone. So in the centers in India like us, everybody is not having facility of inhaled nitric oxide. So in that case scenarios, you would be very happy to use this drug. And the another slide which Dr. Patrick has shown, this slide shows that the Milrinone's effect on systemic vascular resistance or diastolic blood pressure, it is not much different as compared to low dose or high dose. If you see, this is the dual line is low dose and uninterrupted line is high dose. This is high dose effect on diastolic blood pressure, and this is low dose. Low dose of Milrinone is 0.25 to 0.5 microgram per kg per minute, and higher dose, this is 0.75 to 1 microgram per kg per minute. So in Indian scenario, my take home message would be over here that even if you use low dose of Milrinone of 0.25 microgram per kg per minute, you are not causing much of the vasodilatory effect. It means that you will not have penalty of hypertension. Reduced blood pressure. It is not hyper. Milrinone would not cause hypertension ever because it is a good peripheral vasodilator. It is not a vasoconstrictor. Don't have the myth that Milrinone, after starting off Milrinone, you expect hypertension to occur or BP to normalize. Rather, it is other way around. If you want to start Milrinone, your CVP should be normal, child should be better filled up, and third prerequisite should be your blood pressure should be reasonably good. Then and then you use Milrinone. Otherwise, after still starting of Milrinone, you may have hypotension as a penalty. I am not going into detail of this slide because in India, Milrinone is not being used. Now we are going directly to the case scenario 3, now in emergency room, you have 4 days old neonate, Dr. Gupta. When you are on duty, you come across 4-day-old neonate whose saturation is 83. When you are done the echo, child is having severe pulmonary arterial hypertension, severe hypertension as well. Systemic blood pressure is high, as well as on echo there is severe PAH. Child has cold peripheries, low urine output, and there is acidotic breathing. 2D echo you have done and diagnosed as a severe juxtaductal coarctation. LV dysfunction is there. I am giving you the clue. ये पेपर फूट चुका है, आपके एग्जाम में ऑलरेडी डायग्नोसिस दे दिया गया है कि ये कोआक्टेशन ऑफ एओर्टा है और आप आईसीयू से ही स्टार्ट कर रहे हो. बिकॉज आई एम एन इंटेंसिविस्ट, I would definitely take the help of cardiologists like you, and this is the scenario. Which inotrope you would use? Dr. Gupta, Dr. Amit, Dr. Amber. Which inotrope you would use? Let us have the quick answer because we have to go through the clinical scenario further as we are discussing all case scenarios. Which inotrope you would use when you are dealing with a child who is acidotic with juxtaductal severe coarctation of aorta with LV dysfunction? Dr. Gupta, are you able to hear me? Milrinone, okay, very good. I need the discussion on this drug. As recently we have discussed about very good positive points of Milrinone, Dr. Gupta wants to start Milrinone. Anybody else would like to choose any other drug? This is pre-operative juxtaductal coarctation. This child is not operated yet. Huh? So are you sure you want to start Milrinone? If yes, if no, why? Okay, we'll change this discussion further. This is the monitor when you are seeing this child before surgery. So don't consider this blood pressure. This is the blood pressure afterwards. Okay. So pre-ductal, or for example pre-coact blood pressure was 99/66 and the lower limb blood pressure was around 30/20. Lower limb blood pressure is hardly recordable, 30/20, and upper limb blood pressure was 99/61. Okay, so pre-operative you said that Milrinone, somebody has said inhaled nitric, somebody has told Sildenafil. Here the answer is that you should never use dilators before surgery, because see the mesenteric circulation, your blood, the pressure in the lower limbs, in the viscera is very, very low. If you start dilators, your blood pressure would still further fall down. So pre-operatively, I would be happy to use adrenaline and dopamine in this scenario before surgery, and then immediately I'll send this child for the surgery as early as possible. Now given the choice, surgery is done and this is the monitor. Now this monitor's blood pressure, you can tell that this is the scenario where after surgery blood pressure is 111 in upper limb, lower limb blood pressure is 99/60, PAH is persistent, LV dysfunction is still there, we are not unable to extubate. Which inotrope to be used? Now here I would say that yes, Milrinone and dobutamine would be a better choice to reduce the afterload. So Dr. Gupta has said Milrinone correctly, but it should be after surgery. Dilator are contraindicated in any disease where left ventricular outflow has obstruction, like severe aortic stenosis, like interrupted aortic arch, like severe coarctation of aorta. These are the scenarios you are never supposed to start inodilators. You are supposed to start inotropes as well as peripheral vasoconstrictor like dopamine or adrenaline. Do you agree with me now over here? The concept is clear. Dr. Gupta has got the message that Milrinone should never be used pre-operatively in the coarctation of aorta. I need all of you guys to understand this slide very well. After surgery, I do agree that if PAH is persistent, your LV dysfunction is there and blood pressure is fine like this shown in the slide, BP is acceptable, in that scenario Milrinone is a good drug to be used. Okay, this slide you know that where Sildenafil acts and where Milrinone acts. Sildenafil is phosphodiesterase 5 inhibitor and Milrinone is phosphodiesterase 3 inhibitor. Both has pulmonary vasodilatory effect. However, Milrinone has inotropic effect as well, however, as compared to Sildenafil, which doesn't have any contractility effect at all. I am not going into this slide. This is purely for ICU people. This is one of the success story where we have pulled out the child with severe pulmonary arterial hypertension, and a child had a severe coarctation of aorta as well. The child is doing absolutely fine, and you can understand that how a great joy can be passed on to an intensivist and cardiologist who has, with this intense discussion during the care when child was on ventilator, have pulled this child out. So you guys also would be very happy in your professional journey when you would bring this kind of children out. This is a child with PPHN who was a diagnosed case of cystic fibrosis. This is the child who had a severe pulmonary arterial hypertension when was on ventilator, shifted from Madhya Pradesh to us, and has a multiple Swiss cheese BSD. Operated very well, did very well in post-op scenarios with inhaled nitric and HFOV, and is doing absolutely fine. So synergistic effect of HFOV and the nitric oxide is very, very useful. Now we are coming into the indication of sildenafil. We know all these things, that sildenafil is idiopathic. It is used as a class 1 agent in idiopathic PPHN, class 1 agent in pulmonary hypertension secondary to connective tissue disorder, Eisenmenger syndrome, where arterial saturation is less than 85% or right ventricle dysfunction is present, or a patient is in NYHA class 3 or class 4. Post-operative pulmonary hypertension with no residual defect. This is very important, guys, no residual effect, or pulmonary hypertension of newborn, PPHN. So these are the only indications where I would like to give you the message that this drug should be used. Do you agree? Any of you are able to find in all these indications that it is written that pre-operatively large VSD severe PH it should be used? No. Answer is no. If you have left to right shunt and severe pulmonary arterial hypertension, you should not use this drug pre-operatively. Or if you have multiple VSD closures done, severe pulmonary arterial hypertension, there are 3 major ventricular septal defect remaining, or there is a residual defect, do not use this drug. These are the only class 2 or class 1 and class 2A indications where you can use this drug. Many of the people are using sildenafil left to right, left and right. They are using in all scenarios. Any time when severe PAH is seen in the echo, they start sildenafil. This is not true. I want you guys to take home this message that sildenafil should not be used. We need to know when this drug should not be used. Otherwise, I love this slide which I made of Rajnikant, because Rajnikant is a person who breaks all the laws of physics. Do you agree with me? Yes. But if Rajnikant doesn't know that he is bombarding his bullet on which person on the opposite side, the bullet can be on his own brother itself. So you need to know that how to use this weapon and when not to use this weapon. It is important when to use sildenafil, and it is important to know when not to use sildenafil. So these are the guidelines where you are not supposed to use sildenafil. Sildenafil should not be used in large left to right shunts with hyperkinetic pulmonary hypertension or obstructive TAPVC, parenchymal lung lesion leading to pulmonary hypertension, because it would cause VQ mismatch. So I want you guys to remember that this is not the drug to be used in large left to right shunts, obstructive TAPVC, or parenchymal lung issues where you are going to dilate those vessels which are not properly ventilated. So it would cause VQ mismatch. You will use sildenafil, it would give blood to a non-open pulmonary area, and it would cause VQ mismatch. Other indications where not to be used is children with Down syndrome who has severe pulmonary hypertension due to airway obstruction, secondary to airway obstruction, like for example severe laryngotracheomalacia, cleft in the larynx, H fistula, obstructed or a short neck syndrome, obstructive apneas, vagera, etc., where sildenafil should not be used because it would not cause reduction in the symptoms. Those you all know that I am not going into the detail, but side effect you are supposed to keep in mind that anterior optic neuropathy and sudden hearing loss are reported by US FDA in 2008, and all of you should know that in the long run this should be checked. Again, when we go to digoxin, I would like to clear the myth that digoxin is indicated in heart failure associated with reduced systolic function of heart only. So, where systolic function of the myocardium is preserved, role is not well defined. I am telling you that this drug also is being used by many people as an inotrope. Like child is in low cardiac output, start digoxin. This is not the way. Digoxin is only indicated when you have reduced systemic ejection fraction. Systolic ejection fraction. So when you have a reduced systolic function, then only should be used. Preserved systolic function, role is not preserved. Digoxin is used for slowing ventricular rate in tachyarrhythmia such as supraventricular tachycardia, atrial flutter and atrial fibrillation, where class 2A recommendations are there. Still it is not class 1. Lower dose may reduce the incidence of side effects and tolerability. There is no criteria to stop digoxin in Saturday, Sunday. There is no guidelines to say that. So, you have to keep in mind when you are using this drug, you need to understand what are the do's and don'ts. Rapid digitalization is usually not indicated when using digoxin for heart failure. Rapid digitalization may be indicated for treatment of acute tachyarrhythmias. Maintenance dose is equal to twice daily dose for less than 10 years, not in OD dose. Don't use in once a day use. Once a day for more than 10 years. Digoxin holiday is no more recommended. Dose of digoxin should be halved when using amiodarone or your child is suffering from acute kidney dysfunction, acute renal injury. So we have discussed oral therapy like sildenafil and digoxin. We have discussed adrenaline, dopamine, dopamine, Milrinone and Vasopressin. So we have covered almost all the inotrope which are used in our day-to-day practices. Do you agree that these slides have cleared many myths in your practices? For example, dose of digoxin, use of sildenafil. Many of the people are misusing these drugs very often. Now after we have chased discussion of all inotrope, I'll give you the scenario of critical care where a cardiologist has been called, like you people when you would be matured and going into your practice. This is the case scenario has come into the picture. What else is important other than heart? That's what take home message I want to give from this slide. 3-month-old child, 3.6 kg, male, weight loss in short span with fever, severe respiratory distress. X-ray suggested right hemicollapse. ABG is suggestive of CO2 retention. Conventional measures tried, no results. There is persistent atelectasis and child is deteriorating. When echo was done, echo has suggestive multiple VSDs. I am telling you that this child had a severe cardiomegaly. Pre-operatively child has come to us, and when we have done the X-ray, this was the scenario. What you guys would to do it? Now a child is deteriorating, BP is falling, and echo is done. It is suggestive of severe pulmonary arterial hypertension, severe TR, and right ventricular dysfunction. What is the cause? Why this child has deteriorated so badly, and what should be your action? Dr. Gupta, Dr. Ambar, and Dr. Amit. If this child is there in your territory, your ICU, and a pediatrician calls you that Dr. Amit or Dr. Gupta, please guide us what to do. What should be your answer? What should be your answer? How you will deal with this child? Okay, I'll go towards. Now, few of the pediatricians and pediatric cardiologists have told that intubate this child, clear the collapse. There is a hemicollapse. Unless this collapse is improved, your child is not going to be well. So second view was do conventional measures and try to recruit this lung. So everybody was struggling that this child was not doing good because his lungs are not good, and that's why pulmonary hypertension is there. Otherwise, this child would have been easily pulled through without the surgery. So it was not that large VSD. So this is a recently happened case in our unit where we have done a flexible bronchoscopy with 3.7 mm fiber optic bronchoscope, and when we did the bronchoscopy, this was the scene. If you see this, the right main bronchus was completely occluded with a large mucus plug. When we removed this mucus plug, the bronchus was absolutely clear, this infection got cleared up, and child is immediately recovered. This was the large mucus plug which we removed from fiber optic bronchoscope, and after 6 to 8 hours, or 16 hours, sorry, this was the X-ray. Ball was done and it grew staph aureus. Now my question would be that do you agree that if this child would not have been taken care well with bronchoscopy and our critical care unit where I did the bronchoscopy and removed this plug, this child would not have done well? How many of you do agree? Could you send this child for surgery without clearing the lung? Yes or no? No. Very much true. So now you would be having the question that Dr. Amit Chitalia sir, why you have started discussion of lungs? We are here to learn the inotrope. Yes, you guys are very much right, but I want to give the message over here that knowing the drug well, it is not only sufficient. Along with the drugs, you need to understand cardiopulmonary interaction as well. How your heart is interacting with your lungs. And then that's how your child would improve. This is called as cardiopulmonary interaction. For any inotrope or any cardiothoracic interaction, it is very, very important to know your lungs very well. For example, if you will go into your cardiac surgical unit today, and on your duty, if your surgeon calls that my child is not doing good, excellent surgery has been done, a large VSD has been closed, there was a severe coarctation of aorta, we have done excellent surgery from mid-thoracotomy, but child is not doing good, then your answer lies over here. Your intensivist or your cardiologist, are they managing well your lung volume? If you are over distending these lungs, it would cause a vascular stretch and secondary vasoconstriction, and that would hamper your cardiac output. It would cause pulmonary arterial hypertension or underinflation or collapse. Like as I explained you in the previous slide, in this slide there was a collapse. Okay, are you getting my point? This is a collapse, and that collapse has caused a severe pulmonary vascular resistance, and later down the line it has reduced the cardiac output. So it is very, very important to know how your lungs and cardiac chambers are interacting with each other. So not only knowing the drug, but manipulating the lungs also would increase your cardiac output. That's why if you'll read any textbook of pediatric cardiac intensive care or pediatric cardiology, they have a separate chapter about cardiopulmonary interaction. Majority of the people do forget in their ICU practices or cardiology practices. Again, from lungs, I am jumping towards the drugs like fentanyl, ketamine, and newer drugs like dexmedetomidine. If your child is post VSD closure or post arterial switch operation and it has a severe suprasystemic pulmonary arterial hypertension, you need to know that fentanyl and ketamine, dexmedetomidine are the very good drugs to be used in the ICU to blunt down the PA crisis. Fentanyl is very good drug to be used. Dexmedetomidine is a newer modality of treatment. It is alpha agonist clonidine derivative which reduces the tachycardia, reduces the chances of use of opioid. So it is a very good weapon. Now coming to the point of steroid. Is it weapon or enemy? So if you see the flow of our discussion today, we initially discussed the inotropes, then we discussed the oral drugs, then we have discussed the oral inotrope like digoxin, then we discussed the cardiopulmonary interaction, and now we are discussing use of steroid. This is a very, very good modality, not only in the septicemia. I would like to say that this drug is very, very important to be used in post-cardiac surgery for 3 days. There are n number of articles which say that stress dose of steroids like hydrocortisone in the dose of 1 to 2 milligram per kilogram per day reduces the chances of low cardiac output. You can taper it after 3 days very early. Why? Because in the stress of cardiopulmonary interaction or cardiopulmonary bypass, whenever CPB is going on, your demand of steroids goes very high. That's why it is called as stress dose of steroids. Many of the centers, they do give methylprednisolone 20 milligram per kilogram prior day of surgery in the morning, for example 6 a.m. and they take the child surgery in the surgery at 9 a.m. And data suggests that there are less chances of low cardiac output syndrome in these cases where a loading dose of methylprednisolone at 20 mg per kg per dose has been used as a single dose, or post-operatively you have dosed 1 to 2 milligram of hydrocortisone per kg per day for 3 days in 2 divided doses. So, for example, child is 5 kg. If you use 5 milligram IV BD of hydrocortisone for 3 days, there are high chances. The data says that you would have a very good cardiac output. Chances of reduced cardiac output would be low. It has class 2A recommendation. So if we go to the summary, if you remember our first case which we have started managing, Dr. Gupta has very well said that recognize the decreased mental status, see for the perfusion clinical scenarios like reduced capillary refilling time, cold peripheries, lethargy, end organ perfusion which are less, maintain airway, establish vascular access which should be have 2 IV lines according to the PULSE guidelines, push 20 cc per kilo of isotonic saline up to 60 cc per kg, correct hypoglycemia, correct hypocalcemia, and administer antibiotics. These are the first line of therapy. If your child doesn't respond to this, to summarize, this is called as fluid refractory shock, and this definition should come in your first 15 minutes of management. I am again telling you that you are supposed to come to the decision whether a child is fluid refractory or not full fluid refractory. Establish a central venous access in this because you need to measure mixed venous saturation. Begin dopamine or dobutamine therapy as per your clinical judgment. Have arterial line monitoring and judge whether child is fluid responsive or non-fluid responsive. If fluid responsive, child goes into the observation in PICU. However, if child is not fluid responsive, you are supposed to judge this child is dopamine or dobutamine refractory, fluid refractory shock. It means fluid refractory, catecholamine resistant shock. So, if your child is not maintained very well with this fluid therapy and this inotrope as well, which are first line of inotropic therapy, you are going to stamp these kids that this is fluid refractory, catecholamine refractory shock. So in that cases, you are supposed to have mixed venous saturation and you are supposed to judge the use of epinephrine and norepinephrine. Am I right? Are you getting my point over here, friends? So here we are judging that the child is having persistent catecholamine resistant shock. So in that scenarios, begin hydrocortisone if at risk for absolute renal insufficiency. This dose has to be discussed before, as I told you that 50 milligram per meter square per day is hydrocortisone therapy for fluid refractory catecholamine refractory shock. Establish a central venous access, have mixed venous saturation over here, and choose your inotrope accordingly. Now we have discussed all inotrope. We have constrictors, we have dilators, we have milrinone, we have vasopressin, we have epinephrine, we have norepinephrine. So your judgment should be as per blood pressure and mixed venous saturation. For example, if you have a child who has normal blood pressure and whose mixed venous saturation is less than 70, you would choose what? Dilator or constrictor? I need answer from you guys. Normal BP, mixed venous saturation less than 70. Your inotrope would be dilator or constrictor? Anybody is listening? Which inotrope you would use in scenario like normal BP, low mixed venous saturation? Dilator, very good. Miss Ekta, can we communicate with them by voice or they can only SMS? Now in the second scenario, if we say that child is having low blood pressure and your mixed venous saturation is low, okay, mixed venous saturation is also low, it means peripheral perfusion is not good, and your BP also is low, then which drug you would use? Adrenaline, fantastic. So in this scenario you need contractility as well as something which can increase the peripheral vascular flow as well. It reduces the peripheral vascular resistance. So adrenaline in low doses would dilate the vessels and it would kick the myocardium as well. Are you getting? It would kick the myocardium and it would dilate the peripheries. So kicking would be increased and periphery would be dilated. So there would be nice cardiac output. In third scenario, which is on the right side of mine, if child has low blood pressure and warm shock I am telling you, periphery is warm, low BP, and when you did a mixed venous saturation, your saturation is high. Mixed venous saturation is more than 30. In this scenario, which inotrope you would use? I am hiding this slide. Now you tell me which inotrope you would use. Noradrenaline, very good. Or noradrenaline or which other drug? For example, child is post TAPVC repair, Child has severe pulmonary hypertension as well as low BP, warm shock, and more than 70 mixed venous saturation. Which drug you would use? BP is not coming up with the adrenaline. आपने पहले एड्रेनालिन यूज किया है जो डॉक्टर अमित ने अभी बोला, but still your blood pressure is not picking up. Now which inotrope you would use? Adrenaline has been started by Dr. Amit. SvCO2 is still more than 70. Child is in low BP and oxygen saturation is more than 70. Which drug? Vasopressin should be added. So adrenaline, norepinephrine and vasopressin. That should be in the stepwise manner. Step 1 adrenaline, step 2 noradrenaline, step 3 vasopressin. So this is a very important aspect to be understand. If after this inotropes as well, if your child is not improving, that is diagnosed as persistent catecholamine resistant shock, where you are supposed to start measuring the cardiac output, direct fluid, inotrope and vasopressor as per cardiac index, check for cardiac index by hormonal therapies, increase vasodilator effect, and check your hemoglobin as well. If your child's hemoglobin is less than 10, transfuse it. Still child is not improving, it is called as refractory shock. You are supposed to consider ECMO over here. Believe me, early ECMO saves life, not late ECMO. In our centers, we have done a couple of ECMOs in post-cardiac surgery as well as in ARDS physiology, and we have excellent results in children when we have used ECMO earlier, not late. So take-home message would be mixing of wines are important. Prefer identification of etiology first. We are going to end our lectures now, and we are going to summarize the entire slides. Low BP, constrictor should be added step by step. Normal BP or high BP, prefer dilators like Dopamine, Milrinone. If hypertension is there, NTG or SNP. Assess volume frequent after dilator. May need CVP up to 12 to 15 in initial phase of shock, so you need to prefer the CVP line. Prefer combination of one constrictor and one dilator if you have low mixed venous saturation and low contractility. Moment clinical scene allows you to do so. It means that once you have a good feeling of CVP, if you have a good BP, then only you choose dilator. Otherwise, use one constrictor like adrenaline first. Thought of weaning should come as early as possible once child is better. Now we are going to have the quiz. We have ended our entire discussion of inotrope, oral drugs, sildenafil, inhaled nitrate, different surgical scenarios, different case scenarios, pre-surgical as well as post-surgical. We have discussed cardiopulmonary interaction. We have seen that how lung is important. And now we are going to discuss and check that what you have got the message out of this session. Now tell me that which of these three answers are correct in the scenario where you are dealing with less than 70% saturation in mixed venous gas with normalish BP. What does it suggest? Is it low cardiac output needing dilator? Is it high cardiac output, or is it low cardiac output needing pressors? Number 1, okay, it is low cardiac output needing dilator. Dr. Riyanka, option, yes, option 1. Very good. I am very happy to see that you guys have taken a very good take-home message away. Now I am changing and manipulating this scenario. If you have saturation in mixed venous gas which is less than 70, okay, less than 70%, but your BP is not normal, then what is right? 1, 2 or 3? Excellent. So you need pressors over here. Which pressor you would use, Riyanka? Adrenaline. Excellent. So our job is clear over here that when you are needing pressure, when you have low mixed venous saturation, you need adrenaline. Would you be happy in low dose or high dose? Low dose, excellent. And low dose would be defined less than 1 microgram per kg per minute or more than 1 microgram per kg per minute? Excellent, less than 0.1 microgram per kg per minute. That is called as low dose inotrope. So in this, correct answer was, in question 1, correct answer you were right. It was 1 and question 2 was 3. Now one of your pediatric colleague is calling you to do the echo, and child is in shock. Pediatrician is very much depressed that my child is not improving at all. When you have arrived and you have done a subcostal long axis view on sono, subxiphoid, you found that there is more than 50% collapsibility of IVC in relation to respiratory cycle. What your patient needs? Fluids. Excellent. Now, I would give you another scenario. We have given 2 bolus of fluid and you were there standing over there only because it is a reproducible index. Pediatric intensivist told that Dr. Saab, Dr. Priyanka, Dr. Amit, आप यहीं पे खड़े रहो और हमें बताओ कि क्या हमारी फ्लूइड थेरेपी सही जा रहा है कि नहीं जा रही है. आपने आधे घंटे के बाद वापस एको किया. You guys have done the echo after half an hour again, and now you are seeing that collapsibility is reduced. End expiratory diameter in inspiration was 1.71 and on expiration it is 1.6. Now what should be used? Vasopressor or dilator? Dopamine. Okay, I would be happy with dopamine, or I would say that BP is normal. Now after fluid BP has normalized, but IVC has become dilated. BP has normalized, but IVC has become dilated. Peripheries are cold. What inotrope you would use? Vasopressor or dilator? Dopamine. Excellent. That's a good discussion going on. Where periphery is cold, enough fluid therapy is given, adrenaline would not be a better choice. However, you can use low dose adrenaline with a good dose of dopamine. All of you got my point? Very good. So first question was fluid, and second question you would use adrenaline. Third question was dilator. Now in resource limited settings like India, if I ask you the question that which tool from below do you feel is appropriate in hemodynamic monitoring? Minimal invasive plus bedside reproducible tool like USG or echo, sub-sophisticated invasive stuff like LIDCO or PIDCO, or combination of all of above? Excellent. This is very good. I have never expected this type of very good discussion from all of you guys here. I am very happy that this dual tone dialogue and interaction has given me the fruits that yes, many of the centers where cardiologists and specifically pediatric cardiac intensivists and anesthesiologists have started procuring fancy gadgets like PIDCO and LIDCO and cardiac output monitoring and blah blah blah, what kind of the gadgets they have. But believe me, those things are not calibrated for children. Rather than that, a frequent bedside examination, combination of clinical as well as non-invasive tool like sonography and echo is more beneficial as compared to fancy gadgets. So I am very much agreeing with you that this is the correct answer. So to end that, I would like to congratulate to all of you. You guys have done a very good interactive session, and this slide of mine tells you about how innovation and team is important. After you pass out from DNB, make sure that only clinical knowledge is not important. Innovative, locally producible protocols like Prince Charles protocols or Berlin protocols where I have worked might not be true in my unit. I have to reform those protocols at what is good in my unit. So that innovation is very important, and team approach with help of pediatric cardiologist, cardiac intensivist, cardiac surgeon and anesthesiologist. These all 4 people are very, very important as a crucial member in your team, and you guys all have to work with innovation and team approach. Multidisciplinary team approach is very important, as I told you, and pediatricians, pediatric intensivists are one of the core member to manage pediatric cardiac intensive care in your ICUs, along with the cardiologist. Set up fully equipped intensive care unit. Careful planning and systemic approach is very, very important. Why I am telling you? I'll show you one video. We had recently come across the situation where the child post TAPVC repair was not coming up. Are you able to see this X-ray? This is post TAPVC, third post-operative day. Chest is closed and his lungs are like this. Team approach, why it is important. Gadgets, why they are important. This is one of the example. And this child's pH PCO2, if I tell you, is like this. This is the last ABG which we have come across. I have come with the one of the ICU chart. What you will do in this scenario. Now see this. if you are able to read this, first ABG. Okay, I'll read it first. 7.1 pH, 65 PCO2 and 60 PO2. Okay, so what you will do? We have done high frequency oscillator, and if you see, this is a scenario. After high frequency, vitals have become better. He was desaturating very bad. RME dysfunction was there. Severe pulmonary arterial hypertension there because this was delayed TAPVC repair. 2.5 month mixed cardiac TAPVC has come. So this is a recent high frequency oscillator. Use what we have done, and then this child's vitals are absolutely fine. If you can say 100% oxygen, CVP of 8, 150 of heart rate, and the gas is absolutely good. 200 of PO2 immediately after starting of high frequency oscillator. This is the high frequency oscillator, and child has improved very well. So equipments are very, very important. This is another child. Today I had taken the video for all of you who was not getting extubated newborn with post PDA ligation, severe juxtaductal coarctation, and child was not coming off ventilator because of the diaphragm palsy. Child had a left diaphragm palsy where coarctation was operated, and if you see, we have started high frequency, high flow nasal cannula, which is humidified gas, and after third 2 times extubation failure, this child is doing absolutely good, because diaphragm palsy is causing less lung volume, diaphragm was stretched up, and with this CPAP or high flow nasal cannula, that dead space is being ventilated very nicely. So it is very important to understand that where we are getting wrong. Okay, so only cardiac output is not important. You guys are supposed to understand that lungs also are very important. Teamwork is also very important. Like if you say that this is a cardiologist, cardiac surgeon, intensivist, anesthesiologist, and nurse, if you have a team like that, we are not going to have our train running. Who all have different dreams, all have different protocols, all are working without any communication with each other. In this scenario, you would not have good result. You need to have our emergency room or our ICU is like this chaos. If you want a child to survive, you want to lift up that child, team is very, very important. So this is in 2010 when I was in Berlin. We had all team members were cardiologists. She is cardiologist, she was intensivist. I was pediatrician as a fellow. She is a head nurse. She is obstetrician who had come as an observer, and she is, one of the associate surgeon who is there in the ICU. This is our local unit where all the team members are there in post cardiac ICU scenario where left lung was collapsed, and we did a bronchoscopy to remove that the mucus plug, which I had already shown to you. So the take-home message over here is that team approach is very, very important. If we don't have teamwork like this, we are not going to have a salvage of our patient. Okay, so now we change the discussion. How teamwork is important, this is shown in this video. So if you come together, no disease can make your ICU wrong. Right? Thank you. Thank you all. I think it was a great discussion, and I would like to invite you all for participation. If at all,